right, so at this point, I would like to introduce Malika Lamont and Kimberly Hendrickson as presenters on behalf of the National Support Bureau. Give me 1 second while I switch over controls to them.
Can everybody see? Did that work, Tony?
That did work. Everybody raised their hand, so I believe everyone can hear you and see you. I will monitor the question boxes and let you know if anything comes up, but thank you so much, Malika.
Great, thank you. Hi, as Tony said, my name is Malika Lamont, and I'm a project manager with the Public Defender Association. We are the place that the flagship law enforcement assisted diversion program started in Seattle, Washington in 2011, and we are the technical assistance providers for this model nationally and internationally. Today, we're going to be talking to you about LEAD and refining diversion, transforming systemic responses to behavioral health and poverty, and the crimes associated with them. Oh, I'm having technical difficulties here. Just a moment, sorry. Sorry, everybody, my computer is frozen. Oops, there we go. Okay. Next slide. So our learning objectives for today is that you'll understand a systems transformation approach to diversion. You'll develop an informed foundation to assess LEAD's potential benefits as part of a strategy to address law violations related to behavioral health and poverty. And you'll understand how LEAD engages people for whom clinical services are functionally inaccessible. And you'll understand why long-term field-based, non-coercive harm reduction case management is an appropriate response to people whose unlawful behavior stems from behavioral illness. So the Public Defender Association is a nonprofit corporation founded in 1970 based in Seattle. And it originally was the provider of public defense for the Seattle-King County area, and then has now morphed into being a place of advocacy for criminal legal system reform. And part of the work that we do, the programs that are housed in the Public Defender Association, is to develop alternatives to shift from a punishment paradigm to a system that supports individuals and community health. And we also provide technical assistance to advance these goals. And so the LEAD National Support Bureau is a project of the Public Defender Association. It was established in 2016 to support jurisdictions developing LEAD initiatives, and it works both nationally and internationally to provide technical assistance, training, and strategic support around the interventions that we have developed. So what we're talking about today is LEAD as an evidence-based model to be a runway towards system change. And something to think about as we're talking about models and our current models, as well as potentially models that we're looking to move towards, is Andrew Tatarski, who is a renowned psychotherapist, harm reduction psychotherapist, researcher. He talks about models as being a map, not the territory. And they're our way of organizing data so that we can, and it helps us think about what we see, how we feel, and what we do, and the way that we organize the information around the populations that we're analyzing or looking at. And oftentimes it creates, as what Leary calls, another researcher, the reality tunnel. And so are our models potentially creating the problems that we want to address? And then are there other models that could help us address the problems that we are seeing in our society? Sorry about that technical difficulty. So I would just ask you to put that lens on as we go through this process together today. So damaging practices and historical legacies, when we think about the criminal legal system in the United States of America, institutional and structural racism are rooted in American society, and they're embedded in the way that we have executed or created and executed our policies and practices around the criminal legal system. And also throughout American life, such as employment, housing, education, politics, and the criminal policies and practices that we prosecute people for. Decades of punishment for the drug war, crack, heroin, marijuana, and other quote unquote urban drugs. And we've seen how that caused our incarceration rates in this country to surge. We have the largest incarcerated population in the whole entire world. So LEAD is a way to respond. So in Seattle, data showed that 68% of the people being arrested for drug offenses related to crack were Black. They only make up 8% of the population at that time. And we could say that that's directly related to, in the 1980s, continuing for decades, low-level drug crimes. In those arrest rates, there were indisputable racial disparities, as demonstrated by what I spoke about earlier. And after a decade of contentious debate, a group of stakeholders asked, what would we do if we made arrest the solution of last resort for drug offenses? And is there a new alternative with which we could approach the way that we do this work? And some of the stakeholders, just to give you an idea of this group of people, it was public defenders, people that work towards advancing civil liberties, community activists and organizers, public defense, and also the prosecutors and law enforcement. So these are the people that were sitting at the table looking for this new alternative. And what if this new alternative could potentially yield better outcomes for everybody? And the result was law enforcement assisted diversion. LEAD was first piloted in 2011 in one neighborhood in Seattle, the Belltown neighborhood. And it later was recognized by the Obama administration and also the Bureau of Justice Affairs. And it has been recognized as an evidence-based practice. It's been studied. It is something that is funded from a federal level, state level, and local level. And currently there are 6 states that earmark funding for LEAD now, including Washington State.
Hi, Tony. Hi, everybody. This is Kim Hendrickson. Tony, am I coming across with my audio?
Yeah, perfectly.
All right, that's terrific. So I am definitely the new kid on the block when it comes to LEAD. I joined the National Support Bureau in the fall. So it is a real shame that Malika has left the call because she really is the expert on this call. But what I can offer to people as a part of this webinar is my own practical experience. Some folks here may know me from my work in the city of Poulsbo, where I've worked with Mayor Erickson to set up a co-responder program that's now in 4 Kitsap County cities. And I've worked with several diversion programs in Kitsap and King County. So I have come to LEAD from the very practical realization that a lot of the things that we're doing under the general heading of diversion are a great start, but they're not sufficient. So my contribution to this call is to talk about LEAD in comparison to other diversion initiatives and to speak from my own experience about how it really enhances programs like police CIT teams and training and co-responder programs. It would be
I think that's going to be very helpful, very informative. And let's allow a couple more seconds to see if Malika can get back into the webinar. And I don't see her name here. There are some questions that Kim, maybe you can answer in the meantime. One question came from Susan Weisberg. If you can talk about how LEAD programs are adapting their work with clients during the COVID-19 pandemic.
Oh, what an important question. It's something that has been affecting the work in Kitsap County on a whole range of different field-based programs, and I'm sure it's affecting many LEAD sites in King County and across the country as well. What I'm hearing from partners is that the show goes on. Field-based case management is something that's really known and respected for its willingness to do things that are unconventional and intensive, and a willingness to go outside of the box and serve people where they're at in a way that perhaps other systems won't or can't. So what I'm hearing from some partners is that case managers are continuing to meet with clients, continuing to try to address their needs while practicing, of course, social distancing and other precautions. One of the most serious obstacles that I'm finding in Kitsap, where we don't have a lead program, but we have several other diversion programs, is that many of the services that we rely on are either closed or have become very limited in their offerings. So I'm seeing that case managers are continuing to do their work, but a lot of our partners and a lot of organizations that are necessary to help our clients are not operational or operational on a very limited basis.
Thank you very much. And another question while we wait for Malika to come back, and if she's not able to come back, I do have a copy of her presentation and I can just kind of wing it. But I don't think that would be as informative or as well done as Malika. But several questions have come in about what is CIT, and I believe in this context, Kim, can you speak to that?
Oh, goody. That's something where I do have a little bit of expertise, so I'd be happy to try to answer that question. So CIT stands for Crisis Intervention Team, but in many places around the country, it's been mistakenly understood as simply Crisis Intervention Training. CIT developed in Memphis in the late 1980s in response to a fatal police shooting of an individual with behavioral health issues. There was a team of stakeholders that came together in Memphis to try to figure out how police could respond more compassionately and effectively to people that were struggling with behavioral health crisis. And what came out of those conversations was something called the Memphis model. And that's really the basis of modern day crisis intervention team training. The basic idea behind the concept is that you have certain officers in police agencies that voluntarily sign up to be CIT officers. They undergo a heightened level of training to help them understand how to react, respond, manage situations, and involve people that are struggling with mental health and substance abuse issues. These CIT trained officers are dispatched to scenes involving behavioral health crisis. And really importantly, the role of that CIT officer is to build relationships and partners with the mental health, with the behavioral health, with service providers in the area, relieving the burden on police to be the only responders to crisis calls, and really promoting this idea that we're all in this together and that police must partner with behavioral health and other partners to effectively respond to folks struggling with crisis. If I could just add on to that question and talk about co-response models for a moment. CIT programs are not co-response programs. And in fact, the board of CIT International, which is really the leadership organization in this movement, have been very explicit that CIT is not is not co-response. So what's happened in the last 30 years, but really with a lot of speed and energy in the last 10 or 15, is that co-response programs have popped up all around the nation, and a lot of them in Washington state, to give police the opportunity to partner with mental health professionals or behavioral health professionals to actually respond not only to crisis calls, but to respond to calls or individuals that might turn into crisis or might have been a crisis call at a previous time, to try to problem solve and troubleshoot and keep people out of the criminal justice system, emergency rooms, other emergency systems. So again, CIT involves specially trained officers that have skills in crisis intervention. Co-response programs have grown out of the CIT movement, although they are distinct and partner police with behavioral health professionals to both respond to crisis calls and to better prevent them through doing intervention and management before and after crisis calls occur.
Oh, wonderful. Thank you so much. And I've had several questions come in about whether or not these, the presentation will be made available. And yes, yes, they will. I do have them in a PDF format. I will make sure to send that out. There's been a couple of questions about, is there a lead point of contact in Southwest Washington from Jim Jensen? He indicates that he'd like to collaborate. Jim, email me, tony.walton@hca.wa.gov, and I can put you in contact with the National Support Bureau. But from what my understanding, Kim, you guys are statewide, right? You have project directors, or you're able to provide technical support, training, and help stand up programs across Washington state?
Absolutely, and that really is what Malika and I can offer in conjunction with the National LEAD Bureau. LEAD is a program that's been expanding rapidly nationwide, but Malika and I have been engaged to work specifically with Washington jurisdictions that are interested in starting LEAD programs or are pursuing funding, or would like to know about funding opportunities for LEAD programs. So I would encourage anybody on this call that's heard about LEAD and is curious about how it might work in their jurisdiction, or wants to start a program but doesn't know how, to please reach out to the LEAD Bureau or to Malika and I, whose email addresses are on the slide deck.
The LEAD approach and model is rooted in evidence, stages of change, harm reduction. It's peer focused, client directed, and long-term case management. The goal is to divert people out of the justice system, not into mandatory treatment or to specialty courts, judicial supervision, or deferred prosecution. The only requirement for a participant in LEAD is to complete the psychosocial intake and sign a release of information within 30 days for populations other than True Blood. Case management is field-based, not office-based. Case managers need to go into the field, into the places where people are living and existing, and also engaging in behaviors. It is a slow start as expected. Services are not contingent on performance. I apologize for my dog barking in the background. And nobody fails LEAD. We operate within a harm reduction model. We recognize the stages of change. And with harm reduction, one of the most important tenets is self-determination, and recognizing that people move through these 6 stages of behavior change in a self-directed way, and that we are there to support them, because another major tenet of harm reduction is that we do not leave people behind. And we recognize that people did not get to the place of being referred to LEAD because of behaviors that have only been going on a short time. Usually it is a lifelong progression. And so moving through the cycles of behavior change doesn't happen quickly for people. And it's not necessarily completely always a reflection on those delivering the service. It's that the process takes time. So pre-contemplation, contemplation, preparation, action, maintenance, and lapse. We recognize that those are all stages of behavior change. And we hope that, and I intentionally use the word lapse because we recognize that with proper supports in place, ideally a person is not going back to where they started from, that they have the support in place to be able to move forward from where they are now. How does LEAD work? Within the scenario, you're presented with an arrestable defense. An officer can instead offer LEAD as an alternative to arrest and booking. And then officers are also authorized to make social contact referrals. The social contact referral was actually born out of the way that police were engaging with this model. They had people running up to the van in downtown Seattle with crack in their hand because they wanted to get into services. And the officers asked, can we create a mechanism so that people don't have to break the law and get arrested in order to be able to get access to the services? If we know that pretty much any time this person could be engaging in a behavior that would lead them toward a LEAD referral, and that just doesn't happen to be the moment that we see them, can we still refer them into the program? And so that is how the social contact referral was born. If a person accepts, an officer does a direct handoff to case management in the field. The case manager does immediate triage at the scene in the field and begins to form a relationship with the individual that has been referred into service. The case is diverted entirely out of the criminal legal system The criminal filing is not pursued if a release of information is signed and an intake assessment is completed within the first 30 days for participants other than those that are in the TrueBlood population. And we'll get into that more further along in the presentation. So the crucial functions that needed to be funded for any LEAD program and are project management or partnership management. And this should be an independent entity that is arm's length from all other partners within LEAD. And then also there needs to be outreach and screening capacity, case management, flexible funds for client needs, project-specific prosecutors, and data and administrative support. LEAD is a power sharing model as well. Collective governance and management is a non-negotiable element of LEAD. No one partner can be more powerful than another. The policy coordinating group provides a collective vessel, I guess, for joint decision making to occur, and for the policies that will guide the LEAD intervention in the area that is being implemented. The operational work group is what our executive director calls the magic sauce, and they manage the day-to-day coordination of what's occurring with the participants, and case reviews happen there, and they implement the policy set by the policy coordinating group. The operational work group is oftentimes, the essential partners to be there are, of course, law enforcement, because they're the ones that are vetting the people that are being brought forth as referrals, case managers and outreach workers, and that includes those that may be working in coordination with LEAD, not just the contracted case managers in a particular area, as well as prosecutors and the project management team. So those are all the crucial, and sometimes the community attends as well. Communications agreement and coordination among partners that enables consistent alignment and coordination is another integral part of the LEAD power sharing model. And it's a mechanism for review and oversight by civil rights organizations and the community. LEAD isn't a quick fix, as I said before. People do not come to the place of having profound behavioral health issues quickly. It's a lifetime progression, and LEAD is a more complicated than the other light touch alternatives in the system, and it's a complex response to complex issues. As a multi-agency whole system initiative, LEAD requires new ways of doing things, power sharing and commitment amongst multiple agencies. Fidelity to the LEAD model is key to successful replication. A strong and independent project manager is essential, and they must understand the model, steward fidelity, build positive relationships, and excel at both strategic and operational skills. What really sets LEAD apart is that it is collective case coordination. The operational partners meet 2 times a month. Those are the operational work groups, in order to problem solve around specific individuals that may be struggling at that particular moment, and that each element that is at the table has a different perspective in order to be able to address the needs that are manifesting in the behaviors of the individual that you're discussing. And then also that the original diverted case does not proceed to court, but we recognize also that most LEAD participants have cases both pre and post entry into the program, and prosecutors reconcile such cases in each person's individual context, and the officers coordinate about what to do about subsequent offenses. And that is what is really quite different than the system as usual. The system as usual would be that the person just continues to get arrested and booked, and the exact same thing happens, but there's nothing happening in the interim in order to try and meet the needs of the individual and the community. And there isn't that intensive collective case coordination and communication that's happening between all the different partners. And judges can continue cases, grant prosecutor prosecutors release motions, and it operates in collective case management requires that all of us operate outside of a compliance framework only, recognizing that the individual's behaviors and their situation can be, that's what you're seeing happen out or play out with a person's behavior is actually a symptom of how all of the things that have brought them to that point. And what can you do then through that collective case management coordination to actually hopefully address some of those conditions so that that behavior is really addressed in a meaningful way for the person and the community, and it's not just system as usual. And Kim is going to talk to us now about how LEAD differs from and enhances other diversion programs along the Intercept.
Great, Malika, thank you so much. As I mentioned before, Malika is really the subject matter expert about LEAD on this call, and I'm very honored to be here presenting with her. I think my usefulness to people listening to this webinar is my practical perspective. I've worked with many diversion programs, including my own pilot LEAD program in Bremerton. So what I can bring to this conversation is a very practical sense of how diversion works on the ground for the people it's trying to serve, and unfortunately how it often doesn't work, and the disconnect that I've seen personally between plans and application descriptions and what actually happens to the people that we're trying to serve. So if you go to the next slide, please. So what I've tried to do here is present you with an incredibly simplified, unjustly simplified slide of some main diversion programs that have gained prominence in the last 20, 30 years, just to give this conversation a bit of context. This in no way is intended to be a comprehensive list of diversion programs in this country. It's just intended to give you a sense of the general categories that occur before sentencing, pre-sentencing programs, although that True Blood program on the far right of your screen presents an interesting and possible exception. Let me go through these different main categories of diversion approaches, again, in a very quick and simplified way. One of the questions that came in, Malika, when you were making your alternative universe presentation was about CIT programs, which, as I mentioned, started in Memphis in the 1980s. The intent of these CIT programs were to give police officers the training, the tools, the partnerships to be more compassionate and effective when intersecting with people in behavioral health crisis. I also mentioned in response to the previous question that I've seen CIT programs change and evolve into co-responder programs in that fourth column. Co-responder programs started in the 1980s in places like Vancouver and Los Angeles as crisis-specific programs where teams of police officers and psychiatric nurses or mental health professionals would be, or still are, dispatched to crisis calls with the intention of diverting and de-escalating and handling those calls from both a police and a behavioral health perspective. What's happened in the last 15 years, and particularly in the last 5 or 10, is that there's a second wave of co-responder programs that have become popular. And again, particularly in Washington State, there's at least a dozen of them by my count. The idea that police/behavioral health partnerships can and should respond before crises occur or after crises occur. They should not be restricted simply to crisis situations. Another diversion approach that is very prevalent and also quite informal is the varied model of prosecutor-led diversion. And I'm calling this pretrial off-ramps, because the one thing that prosecutor-led diversion initiatives, efforts, programs have in common, it's a way to get people out of the criminal justice system with behavioral health issue before a trial occurs. But this could be pre-charging, this could be post-charging. The point of diversion could be at arraignment, it could be in the middle of a court process, it could even be after a charge is filed and then there's a decision to drop because there's a better alternative that's found. Again, the main point that I want to stress about prosecutor-led diversion is it's quite discretionary and ad hoc, and it can look incredibly different in different places. I would say that the most famous, perhaps the most respected for many people, diversion program centers around therapeutic courts. As many people on this call know, therapeutic courts started in the drug court world in the 1990s. Actually, it started in the late 80s, became more popular and mainstream in the 90s. Mental health courts followed in the 2000s. Many different kinds of therapeutic courts exist today. Where therapeutic courts differ from the two police-led diversion programs I just mentioned and prosecutor-led diversion, they really constitute more holistic programs. But when somebody enters a therapeutic court program, they are part of an organized whole, where there are assigned case managers, mental health professionals, prosecutors. The program has a time of beginning, a very clear time of ending. Charges are handled in a consistent way. I'll say more about that in a moment. Finally, I think we would be remiss on this call if we didn't mention the importance in Washington State of True Blood grant programs. True Blood grant programs grew out of the True Blood lawsuit and the True Blood court settlement. The court decided here in Washington in 2016 that some of the money that was going to the state in the context of penalties for being in violation of the True Blood settlement should go directly to diversion services for individuals who have been in jail waiting for competency testing or restoration, or people that are currently in jail waiting for those services. Malika will have more to say about that in a later slide. I just want to include that in our large overview of diversion because I think these programs are very important in Washington State. Next slide, please.
And Kim, just to give you a time check, we have about 10 minutes left. So based on the remainder of the presentation you and Malika have, just keep that in mind.
With that, I'm going to say I know that there was a webinar on sequential intercept mapping several months ago that I suspect is recorded. Is that correct, Tony?
Yeah, and I can send that out to everyone that's attended today.
So I think if anybody is interested in sequential intercept mapping, I would highly recommend working with Tony to get the previous webinar. What I will say very quickly about this slide that was intended to give you something of an overview of the model is that there's an assumption in sequential intercept mapping and sequential intercept programs. And I need to say very quickly that sequential intercept has to do more than simply with diversion. It's about how access to treatment can be promoted at each step of the intercept, how people can be moved quickly through each intercept. But again, there is a diversion element to it. How can people be diverted from the justice system into community care at different points in their intercept with the criminal justice system? The idea that I want to stress with this slide and then quickly move on is that most diversion programs assume that there's a moment of intercept, right? There's a moment where there's an off-ramp. Well, by offering the right service or program, somebody can get out of the criminal justice system and enter into community care. One of the things that I find most important about LEAD is although it definitely has a point of beginning intercept, it's at that intercept 0 mark. As Malika mentioned in her presentation, much of LEAD involves social contact referrals, which occur before a crime or a possible crime occurs, before the point of arrest. So there is a beginning point for the LEAD program on the sequential intercept model, but part of the strength of the model is it assumes that people will touch many points of the system at many points of their lives and sometimes at the same point in their life as well. Malika mentioned in her presentation, people don't move quickly through cycles of change. Harm reduction recognizes the fact that relapse is something to be expected and change doesn't happen quickly. One of the strengths of the LEAD program is that case managers can intervene when individuals are in the community, in the jail, working through court agreements, trying to stay out of court, working with law enforcement. It's a strategic intercept approach that operates on all points of the continuum, even though the beginning intercept is typically at 0 or 1. Next slide, please. Next slide, please.
I'm having technical difficulties, sorry.
Okay, thanks so much, Malika. I want to make sure I say this clearly so I'm not understood. Diversion programs in all of their forms are worth our respect, our improvement, taking very seriously. I think being critical of diversion programs runs the risk of discrediting the important project of diversion, and that is something that I don't want to do. However, as I mentioned in the introduction to my presentation, I am somebody with practical experience trying to get people with behavioral health disorders care and assistance through diversion programs, and there is a depressing disconnect often between how programs are designed and how they actually work on the ground. What I want to talk about very quickly is some of the shortcomings in diversion programs, again, with that larger framework of respecting the work that many people in these programs do and the importance of the attempt that they're making. Critical question I think that we need to ask when assessing diversion programs is what happens next question and the who is being served question. My point here in this slide is that diversion, even though it's incredibly well-intentioned, is often very short-term and limited to a particular subset of individuals with behavioral health issues that are looking for or in need of assistance. When I talked about police-led diversion programs like CIT teams or co-response teams, they tend to be crisis-focused, or even when they're non-crisis focused, they're very much about problem solving, taking care of a particular issue, getting somebody to care in the moment. They're not designed as long-term programs. And when we talk about prosecutor-led diversion, and please forgive me for generalizing, there are many variations. They're highly variable, they're highly discretionary, and individuals are often on their own to satisfy requirements for evaluation or treatment that prosecutors put in place. It's very difficult for people that have been struggling with issues on a chronic basis, co-occurring conditions, have 1,001 obstacles to care, to be left on their own to satisfy court diversion agreements without support systems in place. And I'm afraid sometimes prosecutor-led diversion sets people up for failure. Therapeutic courts, as I mentioned before, are the gold standard for many people in terms of diversion, and they certainly deserve our respect for the incredible work they do for many people. But the who is being served question is critical here. There are many people that do not have the organizational capacity to participate in highly structured therapeutic court programs, which typically involve getting to a court, satisfying court requirements, meeting in an office-based setting with behavioral health professionals, fulfilling abstinence-based requirements. Again, therapeutic courts are terrific for some people, but I think it's important for those of us that are interested in diversion to keep coming back to that question about what about the everybody else? What about people that are engaged in recovery that looks different than conventional court-based or abstinent-based recovery? What about people that don't have the capacity to get to a courtroom on a regular basis? I could speak about this longer, but I won't for the sake of time. Next slide, please. What I'd like to stress here is that LEAD enables a collective ongoing response, a different kind of diversion than other programs and initiatives that I've been talking about during my presentation. I don't have time to give justice to all the ways that LEAD is different from other diversion approaches. And I certainly don't want to say LEAD is a quick fix. Malika made it very clear in her earlier slide that there's a long time horizon when people get involved in LEAD, and no one has failed from the program, and there is no end date to the program. We are in it with people for the long run. The different approach that LEAD takes to diversion involves a collective strategy where there are many players across systems that are looking to enhance outcomes for individuals that have frequent contact with the criminal justice system. But I think most importantly, it's an ongoing response that understands that change happens slowly for many people, and there are many barriers to care that make conventional office-based or court-based treatment plans simply out of reach for some of the people we most need to serve. Next slide, please. Okay, important point, and this I'm speaking from personal opinion. LEAD is not and should not be considered a replacement from other diversion programs. I think what you might have deduced from my quick presentation is I see LEAD as solving problems that other diversion programs can't. However, I don't think that LEAD should be seen as a replacement or an alternative, but it's better understood as an enhancement or a complement to diversion efforts that are already happening in our communities. It expands access to care for more people. It brings care out of an office-based clinical environment and into the streets for people that can't access outpatient care in conventional ways. And most importantly, it's ongoing and recognizes the need to stick with people through the different stages of change that Malika talked about. It's not a one and done or a quick problem solving approach, but a real frank recognition that a lot of the people we're trying to serve through the LEAD program need ongoing care and support. Malika, could you say a few things about the True Blood program?
Yes, sure. Sorry, I had to unmute myself, technical difficulty. As Kim mentioned, you all, and I think many people are very familiar with, you know, True Blood was about being able to work with that whole decision and the resulting court situation and the money that has gone out to communities was about being able to work with the competency-based population in a way that was better than what has been business as usual, where people are put into hospital settings and then they're overcrowded. A combination between True Blood and LEAD is a means by which to move care for the competency population to the community. And Seattle King County has developed, as you can see by this slide, all the different players that are coming together in order to meet the needs of the True Blood population. The intensive case management model that is signature within LEAD that was developed by Eileen Corcoran, rest her soul, that is hands-on, community-based, long-term engagement with people that have intense behavioral and ongoing behavioral health challenges. And so the Public Defender Association in Seattle has been the coordinating body between with what we do already with LEAD, with law enforcement, expanded clinical services, prosecutorial department partners, and community involvement. And we're laying that framework onto a response for the True Blood population. There are a few things that were altered, recognizing that when you're working with people that have these really intense needs, that there may be a longer lead up engagement with people to get them to be able to sign documents and so that release of information and that go through the treatment planning process. So some of those timelines have been extended beyond the 30 days that is typical with the LEAD approach. But it is a mechanism by which to have ongoing engagement with people and begin to meet those needs for this really high needs population.
Thanks, Malika. Tony, were you going to jump in and say a few words about HCA's role in lead state expansion?
I think since we are 2 minutes already over our allotted time, and I would like to try to get to some of these questions. If anybody has any questions specifically about Substitute Senate Bill 5380 or House Bill 1767 and some of the work that the Washington State Legislature has done to expand LEAD across Washington State, please do contact me. But yeah, in the 2019 biennium session, close to about $8 million was appropriated for LEAD expansion under two different bills in the legislature. So we got lots of really good questions, and I want, while some people are kind of hanging out past the 9:30 deadline, I figured I might as well answer them since this is being recorded and then it can be shared with everyone. One was, what were the scientists' name that were mentioned who talked about the model being a guide? Malika, I believe that was one of the first.
I was just saying models in general. I was not specifically talking about LEAD, but that's Andrew Tatarski. That was who I was talking about.
Andrew, okay, and it will be in the presentation, the PowerPoint that I email out. What agency or university is spearheading LEAD data collection and interpretation in Washington State, if any?
So the Heart Center for Harm Reduction Based Research, they out of Seattle, they are the ones that are working with us, and the University of, so the researchers are housed within the University of Washington, but then they also have, there's a team of researchers from around the country, and I'm sorry, I don't remember all of the institutions that people are affiliated with, but I can get you that information.
Great. And then Dina Geisler indicated that I think this is important to note that she works in Clallam and Jefferson counties with clients to provide employment case management, and had a client who had their first interaction with police while also having untreated schizophrenia and is now stuck in the system currently at Western State Hospital. This would have been a great process for him. So not as much of a question as a anecdotal story, but one that I feel is important within the context of the conversation. And that's unfortunate that more services weren't available for that individual. Brianna Rollins asked, which providers participate in the case coordination? I'm thinking the question is about which behavioral health agencies or treatment providers are active in that case coordinating piece.
So it's all dependent upon, you know, who's involved in your community. But when I mentioned that all of the case management that is involved, so in Seattle and King County, for example, we had the REACH case management, which was the contracted case management arm for the lead intervention that I was helping start in Burien. And then there were other True Blood related case managers from different programs. So I'm going to go back a little bit to the slide that talks about that, so then you can see that it's a multidisciplinary team of expanded clinical services. So whoever is involved with an individual or with your intervention, so it's case management, law enforcement, prosecutors, and the project management arm are the essential pieces to be at the table for operational work groups.
Awesome. And then one question asks, are lead services offered to youth and minors, or is it adult specific programming?
The interventions in Washington State are adult specific. They're Naja Morris, who is the director of the Lead National Support Bureau, she helped work with a program that was very unique and it took a lot of intensive and integral planning in Texas, but it is not something that has been replicated for youth populations, generally speaking.
Okay, thank you. Hold on one second. Can you share how you measure success for LEAD participants? How should communities using LEAD evaluate their programs to ensure they are serving the LEAD participants in the best manner possible? Are there metrics used across all communities? And that came from Kim Goodman.
I don't know the exact, you can look at the evaluation that has been done for LEAD in Seattle. It was completed in 2015, I believe. So it's still, I mean, as research goes, it's very relevant still. We do give examples of metrics and what you should be looking at as far as like from a process perspective of starting up your program. And then also there are different places that, because every community is different on what they collect as far as data, but we're in the process of developing. So I'm saying all this to say, we're actually in the process of developing standardized metrics of what a community should look at right now.
Tony, can I jump in on that one?
Yeah, sure.
I mean, there's a sophisticated answer to that question, and there's a slightly more simplistic one, and I'd like to take the simplistic. At the end of the day, LEAD is a public safety program, and the yardstick to measure results for LEAD participants and the programs in general has to do with reducing contacts with the criminal justice system. So, you know, again, I would like to stress that it's more complicated than that. But if you're looking for a simple way to measure whether these programs are working, and importantly, whether they're a proper use of taxpayer funds, I think it's important to go back to the essence of this program, which is designed to reduce individuals' contact with the criminal justice system that have a history of repeated contacts and high recidivism.
Thank you. And just to be cognizant of both of your time as well as people that attended, I'm just going to pose one more question and then end the webinar. Thank you all for staying after the allotted hour. Technical difficulties had prevented us from getting to all of these questions, and I apologize. The final question is, have you seen that offenders continue to offend because they are not entered into the system, or are you finding that it is truly the disease you are addressing? And that came from Terry Lennox.
We are seeing that. Oh, go ahead, Kim.
No, I'm going to just jump in with a practical perspective of what I saw managing a lead program in Kitsap County and running co-responder programs. What I am seeing overwhelmingly to be true is a disconnect between services that are available and services that people need. So, on the topic of, why do people continue to offend? The answer that I'm seeing from a county that has some terrific programs, but some significant gaps. We don't have enough field-based assertive case management. And without that critical piece that LEAD provides of giving people ongoing, intensive, really client-centered care, the barriers are just too high for many people to make behavioral change.
And with that, I think that's a perfect note to end the webinar presentation on. Thank you all for attending, and thank you for staying past the allotted time that we had. I want to thank Malika and Kim, especially for presenting on all of the work that you're doing and informing and educating everyone about how LEAD as a model can be included and implemented within various communities to address the high needs of the population. So thank you so much. And everyone, I will be sending out webinar recording as well as PDF of the slides presented. So take care, be well, stay healthy out there. And if anybody has any questions that were not answered, please feel free to either email the presenters. Their emails are on the last slide of the presentation. Or you can email me as well. I'm more than happy to help in any way. But thank you all again.